Welcome to the PD Exchange, the Peritoneal Dialysis podcast, where we discuss the latest and the best of peritoneal dialysis literature. I am your host, Dr. Nikhil Shah, a nephrologist at the University of Alberta, Edmonton, Canada, and with me is my co-host, Dr. Jeff Pearl, who is a nephrologist at St. Michael's Hospital at the University of Toronto, Canada. Dr. Pearl is the editor-in-chief for the journal Peritoneal Dialysis International. Today, we are discussing the recently published and freely available online, the ISPD Catheter-related Infection Recommendations 2023 update. And to discuss this important manuscript, we have the lead authors, Professor K.M. Chow and Professor David Johnson. Professor Chow is the lead author for the Hong Kong team. He is currently the Chief of Service in Department of Medicine and Therapeutics at the Prince of Wales Hospital, and he is the chairman of the Hong Kong Society of Nephrology. Professor Johnson is currently the director of the Metro South Kidney and Transplant Services and the medical director of the Queensland Kidney Transplant Service at the Princess Alexandra Hospital in Brisbane, Australia. He is also the president of the Australia and New Zealand Society of Nephrology. Welcome all, and thank you for discussing this important paper with us. And I will hand it over to Jeff.
Thanks, Nikhil, for that introduction. And I want to thank David and KM for taking the time to join the podcast today. I also want to point out that there's many benefits to ISPD membership. The guidelines are freely available, but lots of interesting content and activities. So please visit ispd.org and consider joining as a member. I also want to point out that unfortunately, we ended up being a bit of a manel today, and that was not by design. For those of you who don't know what a manel is, it's an all-male panel. We had invited a number of speakers to reflect the variety and diversity of the authorship of the guidelines as well as the society. But due to scheduling issues, those representing the guidelines are Drs. Johnson and Chow today. So I do apologize, and please feel free to look at the also freely available editorial written by Ana Figueiredo from Brazil on the ISPD guidelines that we're talking about. So I'm going to start off with you, David. Just a very simple question. Can you tell us where the 2022 guidelines end in terms of what they cover versus these guidelines? You know, we have two ISPD guidelines relating to infection. Can you just talk a little bit about what the scope is of these guidelines and the scope is of the guidelines that were published in 2022?
Well, similar to what we did with the 2016 and 2017 guidelines, the 2022 guidelines were primarily dealing with peritoneal dialysis related peritonitis. But the guidelines have just now been released in 2023, relate specifically to PD catheter-related infections. So we're specifically talking about exit site infections and tunnel infections as opposed to peritonitis.
Right. But of course, it's kind of difficult to tease those apart for many different things because, of course, they're related because we're doing many things to prevent exit site and tunnel infections, of course, to prevent peritonitis. So undoubtedly, there's going to be just a little bit of overlap in some of the recommendations. For example, prophylactic antibiotics at the time of catheter insertion, I imagine, would straddle between the two guidelines.
Well, in fact, actually, you probably notice a difference from these catheter-related infection guidelines compared to the previous is that we've actually tried to align sort of the format and structure very similar to the peritonitis guidelines. So there are intentionally those overlaps in terms of prevention, etc. And even with the definitions and targets, you'll see there's quite significant parallels with the peritonitis guidelines.
Right. And so I think that brings me to my next question. You know, the guidelines are really nicely organized into definitions, prevention and prophylactic strategies, and then we'll talk about treatment. Can you take us through from a definitions and prevention perspective, what's new in these guidelines compared to previous guidelines?
So I guess we've provided a clearer definition regarding the in relation to exit site and tunnel infections. We have also, provided additional aspects to the definition of those. So we've, similar to the peritonitis guidelines, we now talk about cause-specific catheter-related infections. So, subclassifying the exit site infections and tunnel infections according to the particular causative organisms. We also have time-specific definitions. So we have a PD catheter insertion-related catheter-related infections. So that is exit site infections and tunnel infections that occur within the first 30 days of PD catheter insertion are defined as insertion-related. So we add those in. We provide greater clarity about how to monitor and report exit site infections. And for the first time, we've also provided a target benchmark rate. We're aiming for essentially infection rates of less than 0.4 episodes of exit site infection per year.
Similar to peritonitis, if I'm not mistaken.
Well, in fact, identical to peritonitis.
Okay.
So
yeah.
There was
0.4 is the number for everything.
0.4 is the number. So as I said, we have tried to do some parallels, and and we didn't make it 0.4 just because that was the peritonitis guideline. There was more science around it, but it does make it easier to remember if there are those parallels between peritonitis and catheter-related infections.
And one thing practically is sometimes people send pictures of exit sites and they're nasty and they're angry, and it's always hard to discern infection versus irritation or inflammation. What would you say, to the clinicians out there that really struggle with this? How do you tell an infection from something that's irritating it because of the ointment that's being used or some allergic reaction? I think that gets a lot of people confused, and I would say we probably overtreat a lot of exit site infections that might be irritations.
Yeah, look, I think that's true, and that's what when I mentioned before. We try to provide greater clarity around the definition of an exit site infection. So the exit site infection really depends upon the presence of a purulent discharge. To actually be absolutely categorical, say it's a definitive exit site infection, there must be purulent discharge present, and it can have associated, erythema, surrounding erythema, tendinous induration. They're nice to have additionals. But we've also clarified that if we're simply just talking about erythema without, or tendinous or induration without actual purulent discharge, it may be an exit site infection, but it's not sufficient to diagnose infection. Only purulent discharge is sufficient to diagnose infection.
And you would suggest we swab all purulent discharge?
Yeah, oh yes, you absolutely swab purulent discharge. But if you've got purulent discharge, you can be very confident that's an exit site infection, and you should treat accordingly with antibiotics. If all you've got is erythema and irritation that you discussed, it may be an exit site infection, or it may just be irritation, chemical irritation from whatever cleansing agent you're applying to the site, or to that reaction to the tape or the dressing. And that will require clinical judgment to determine which of those it is. It may be appropriate sometimes if you've got erythema without purulent discharge to prescribe antibiotics. It may be appropriate to not treat those with antibiotics. It's similar to bloodstream infections. We've got definite, suspicious, possible. Purulent discharge makes it a definite. If you've got erythema in that, it's possible, but it may not be.
So if we're aiming for that 0.4, what would you do with those ones that are not purulent but angry? Would you include those? Would you be more inclusive to count that in the exit site infection, or should units be very strict to that definition and in terms of their reporting?
Essentially, if someone has diagnosed an exit site infection, either on the basis of purulent discharge or because they feel that clinically, even without a purulent discharge, it's the evidence is sufficiently strong to warrant treatment with antibiotics, then that should be counted.
So it's the unit that has made that clinical decision, either because of purulent discharge or suspicious enough to warrant treatment, that we should be counting that in our programs.
Yes.
Okay, I think that makes a lot of sense. And then what about tunnel infection? Take us through the definition of tunnel infection. It's a little bit more of a tougher diagnosis to make, in my mind. And, tell us the role or not of ultrasound, because this comes up always, to look for a collection under the tunnel.
Yeah, so we've defined tunnel infection as the presence of erythema, induration, tendinous along a tunnel tract, with or without the presence of an ultrasonographic evidence of a collection. And there was quite a bit of debate amongst the team about the role of ultrasound. So in general terms, it was ultimately decided that the presence of an ultrasonic, evidence of a collection, obviously is good supportive evidence of a tunnel infection. It's not sufficient in and of itself to diagnose a tunnel infection, because there could be other reasons for it, such as the seroma, hematoma, etc. So in general terms, you need that evidence of inflammation. So erythema, induration, tenderness. If you're suspicious of a tunnel infection and you're wanting to shore up the diagnosis, then ultrasound should be performed. You should have a low threshold for doing an ultrasound to confirm a tunnel infection.
For all those POCUS people out there and who are running around with ultrasounds around the hospital, don't go asymptomatically scanning for tunnel collections, because I think what you're saying is that that ultrasound plays a supportive role. It doesn't play a diagnostic role in and of itself.
Correct. It helps to shore up a diagnosis, but you shouldn't be screening asymptomatic people for collections, because that the risk of coming up with false positives is high.
No POCUS tunnel ultrasounds in asymptomatic people.
Yeah, unless you've got a clinical indication for doing the ultrasound.
And
I fully agree with that. In fact, we should be aware of the infection in PD patients, but at the same time, we really have to have the antibiotic stewardship program. We do not want to overuse antibiotics. So David has said very nicely that we should be looking out for infection. But if there's no prurient discharge, don't try to put in antibiotic just for the safety or the peace of mind. We should have a strict definition of exercise infection. Yes.
Thanks. And KM, thanks for that comment. Maybe I'll turn to you. Speaking about antibiotic treatment, tell me what's new in terms of treatment of exit site and tunnel infections. What are we expecting to see in this 2023 version that's different in terms of treatment compared to the prior versions?
Well, in 2023 guidelines, we do think that the spectrum of the bacteria should not change too much over time. So we are still targeting the gram-positive, in particular Staph aureus infection. So as an empirical treatment of exercise infection, we still advocate oral antibiotics to cover the gram-positive and most of the Staph aureus. Of course, we also need to look at the patient's background, whether he or she has been having the Pseudomonas, and then we try to cover that as well. But the 2023 guideline to try to look at the duration of the treatment. In the previous guideline, it was almost a mandate to treat all exercise infection for 2 weeks or 3 weeks for Pseudomonas. Now, is it the longer the better, or should we have some early assessment? The key for the 2023 guideline is that we should ask the patient to come back for a clinical assessment, say 1 week after starting antibiotics. We should not just ask the patient, okay, you have exercise infection, go home and take the antibiotic for 2 weeks and say bye-bye to the patient. We should actually have a clinical assessment to see whether the exercise infection is improving or not. And at the same time, we take the opportunity at 1 week to receive the bacterial culture sensitivity to see whether we need to change the antibiotics. And if the patient's exercise infection really recover very nicely, say at 1 week, we may have to cut short the antibiotics duration for, say, 10 days. If this is enough, then we do not have to prolong the antibiotic unnecessarily. This is the new guidelines key change.
Yeah, that's really interesting. So basically, we need to assess the exit sites after a period of treatment with antibiotics. It's not just 2 weeks and reassess at that time point. Because you're right, there are risks with giving patients extended courses of antibiotics unnecessarily. And also, it's important to clinically observe. I'm going to ask you this because it's, a picture's worth 1,000 words when it comes to exit site care and management. And I can tell you in my program, the nurses are always sharing pictures and tracking pictures of exit sites as we treat these exit site infections to monitor for progress. Do you think it's part of routine clinical care in 2023 to document exit sites that are problematic or infected with pictures over time? Do you think that is something that we have to think about more as a PD program, to build in that infrastructure to be able to do that in a compliant way with our local privacy laws?
As we mentioned at the beginning, we want to have this guideline to be applicable to all diverse situations in different countries. So we do not really say it must have a picture to document it for all patients. Some of those patients in doing PD may be unable to have their picture taken, so we do not really make it a mandate. But yes, you are right, Jeff. In my center, we also use an iPad to take a picture, upload into the computer, so that every clinicians, nurses can get access to the picture at the day 1, and then when they come back at day 7, we can also compare and see whether this is improving or not. But I mean, the patient is another key stakeholder to assess the exercise. They look at the exercise daily, they do it, take care of the exercise daily. So they should be able to tell us whether this is improving or not.
Yeah, no, that's a really great comment. And the other question I wanted to ask you is, you know, for Pseudomonas peritonitis, if I'm not mistaken, ISPD infection guidelines suggest to treat with 2 antibiotics, correct? For Pseudomonas peritonitis. But for a Pseudomonas exit site infection, the recommendation is 1 antibiotic, correct?
Yes.
Can you comment on why there's a difference? And I've always wondered that myself, between 2 for peritonitis and 1 for exit site infection in terms of the number of antibiotics.
In fact, Pseudomonas infection is not easy to deal with, we all agree. And that's why for the exit site infection and peritonitis infection of Pseudomonas, we always want to have longer duration of treatment. Whether 1 is better than 2 or we should have 2 universally for exit site infection as well, we do not have a head-to-head comparison or randomized control trial. But you're correct. If the Pseudomonas infection is really not improving, say when they come back for follow-up, and we find out, okay, this is really a case of Pseudomonas. Sometimes we do increase the duration to 3 weeks, and we also want to add 1 antibiotic, but it's not a must because we don't have a solid evidence, grade 1A evidence to say it.
I've always thought about it as, you know, peritonitis is severe, and you've got 1 shot with severe consequences. With an exit site infection, you may have a little bit more breathing room to assess the efficacy of 1 antibiotic. And as you said, assess and change course and consider adding the 2nd. So I think that's quite sensible. It makes a lot of sense to me.
That was a consideration in our group as well regarding that. I mean, ideally, all other things being equal, 2 anti-pseudomonal agents are better than 1. However, in the setting of exit site infection, you're usually dealing with a less severe infection. You're usually talking outpatient management. And if you use 2 anti-pseudomonal agents, you're generally hospitalizing the patient because you consider your options, your oral options for outpatient treatment are limited. So it is a compromise. Most likely, given that it's a milder infection, you usually can get away with it. But certainly, if Pseudomonas infection is not responding to 1 agent, then the next step would be 2 agents and probably hospitalize.
I really like that 1 week assessment. I think that's really great. That emphasizing that. KM, one other question about methicillin-resistant infections, and of course, in the peritonitis guidelines, the degree of methicillin resistance dictates our empiric choice of antibiotic in our program. Is methicillin resistance at all a concern for empiric treatment of exit site or tunnel infections in programs that have high rates in terms of your first-line oral therapy? Because there's very limited oral therapies for methicillin resistant organisms, but what would you do in a program that has a high rate of methicillin resistance, and how would you guide them in terms of first-line exit site and tunnel infection treatment?
Very nice questions. For peritonitis and exit site infection, the empirical antibiotics may not necessarily tackle the methicillin resistant strain. So it really depends on the center, whether they have a high prevalence of MRSA infection or that patient has been a known carrier of MRSA, then we will be alert, okay, this may not be a simple case that we can tackle with the oral antibiotics. For those high MRSA prevalence centers or the patient has been known to have recurrent MRSA infection, well, we will have to give the intraperitoneal vancomycin to cover that almost day 0 when they come in with a nasty exit site infection. But otherwise, we can still wait because the culture will come back quite soon for the MRSA infection. So as long as we have a chance to get the patient to come back, we can always change gear.
Right. No, that's, again, it speaks to some of the differences between exit site and tunnel infection management versus peritonitis, a little bit more time to reassess things. One other question I was going to ask you, David, what would you highlight as a controversy in the guidelines, or what would you say is something that is probably the most controversial? I'm going to ask you, David, first, and then KM, I'd like to get your perspective if you agree or have another controversy.
Well, look, based on reviewer comments, probably the downgrading of the mupirocin from 1A to 1C was probably the most controversial in that, because yeah, a lot of people have embraced the mupirocin as very high level evidence up until this point in time. So I think that was probably the most controversial.
And what changed? Why? What happened? How did it get demoted?
Look, it was just really a more critical appraisal of the evidence, to be honest.
So a fresh set of eyes on predominantly the same evidence.
Fresh set of eyes, predominantly the same evidence. There had been a Cochrane review as well. That's an additional Cochrane review that had come up. Had indicated that the evidence was uncertain. So, but yeah, it was really just a fresh look.
And when you say mupirocin, are you talking about mupirocin plus gentamicin, or is that a mupirocin specific?
I should say topical prophylactic antibiotics. So mupirocin, gentamicin, all those things.
Okay.
Yeah. Although, as you know, most of the studies are related to mupirocin. Yeah.
We're gonna talk about gentamicin in a minute. KM, what were your thoughts about one of the more controversial parts of the guidelines?
One of the parts that I struggle and our team are struggling with is the treatment of a non-mycobacterium and non-tuberculosis mycobacterium. Because nowadays we are seeing more and more MOTT mycobacterium other than tuberculosis exercise infection. I'm not sure about whether this is the global trend, but at least in many of the centers of the offering writer teams, we do see more and more cases of so-called culture negative exercise infection, and then with time it turned out to be a mycobacterium abscesses, mycobacterium fortuitium. This kind of exercise infection is very difficult to treat. We do put down, usually this kind of organism requires 4 weeks of antibiotics, usually double antibiotics. But we struggle whether we should actually go more aggressive in removing the catheters, because this kind of organism is quite difficult to get rid of without source control. So we are not as strict as say that, okay, mycobacterium other than tuberculosis, remove the catheter to settle the existing infection. We still give a leeway for treatment with antibiotics. But to be honest, there's no big case series to document which one is better. So this is one many of the PD societies going to encounter in the next few years. Hopefully, by the time we have the chance to rewrite the guideline a few years down the road, we got more data to support how to deal with these kind of organisms.
Yeah, no, so I think that's a really interesting point. So for mycobacterial, we're talking about atypical mycobacterial. Of course, we're not talking about tuberculous mycobacterium. You're saying the controversy is whether to remove the catheter right away or to provide a course of treatment. Is that what you're highlighting? Is what the strategy is?
I think this is the two most commonly adopted strategy to deal with the atypical mycobacterium. Yeah. And in a 2023 guideline, we do put up a session on the salvage strategy. It's not a either or, say antibiotics or removal. We can have another salvage strategy, say relocate the exercise, trying to keep the catheter so that the patient can be still maintained on PD.
Yeah.
This is a promising strategy in between drastically remove the catheter versus just conserve with just antibiotics.
Right. So going back to atypical mycobacterial infections, a lot of the times in programs, the sensitivity results can take quite a few weeks. So in many cases, you're blindly treating the exit site infection with antibiotics that may not necessarily be the right antibiotics. So I struggle with that in my program because the sensitivities can take up to 2 months to come back for atypical mycobacterial infections. And, unless there's been an issue with a very frail patient or somebody who wouldn't tolerate catheter removal and interim hemodialysis, we actually, in my program, rightly or wrongly, have been more aggressive at catheter removal for detection of it. But again, I think you point out the controversy in that practice. And you say that there's other salvage techniques that we can employ beyond just removal or antibiotics that we can reassess. And I want to talk about those salvage techniques. Can you, so, of course, the treatment for a refractory exit site infection oftentimes is removal. And depending on the organism, we can either remove and reinsert in the same procedure for some organisms, and for others we can't. But tell us a little bit about what you mean when you say salvage techniques. I think what we're saying is we're not removing the catheter, but we're doing something to it to try to address the exit site infection. So tell us about these salvage techniques, what they are, and who would be a candidate for a salvage technique.
Yes, yeah. There are some conditions that will not use salvage strategy. Say if the patient has a catheter exit site infection and then progress to peritonitis, then we have no choice. We have to remove the catheter to save the infection from getting worse. But if there's refractory catheter-related infection, say the patients have received antibiotics 1 week, 2 weeks, and then 3 weeks, still there's no improvement, but somehow there's no peritonitis, and the deep cuff, the internal cuff is still not yet involved, then these are those patients we want to keep the catheter, maintain the patient on PD without switching to HD. Then some of the strategy in the new guideline include, for example, remove the catheter, at the same time we can insert it at the same time in the same session. But this will have the complication of all those new catheters, say dialysis catheter leak, also flow dysfunction. So we also recommend other new salvage procedure. For example, shaving or removal of the external cuff when they are exposed with infection. And this can be done at the bedside procedure in the outpatient clinic, as long as the clinician is experienced in this kind of shaving or removal of the external cuff. And if this can be done properly, sometimes we can get the infection under control. And apart from this shaving of the external cuff, we also propose some new strategies. For example, deroofing the catheter and then exposing the external part of the catheter and trying to relocate it. Sometimes we can expose the external part of the catheter to ensure the deep cuff is not infected, and then we can even connect with a new catheter. And these are the new strategies that are supported by some case series to say that at least we got 50 chance or even more than 50% chance to salvage the catheter, and therefore the patient can be maintained on PD.
Yeah, no, and I think and maybe I'll get David to comment on this as well. One of the things that I think the ISPD could do, and Anna pointed this out in her editorial, I encourage you all to read the editorial, is the guidelines are really the gold standard on what we should do, but we need a lot more education to follow. And I think videos and there's tremendous interest in understanding how to properly do catheter salvage techniques. And I think that it would be really important for us to think about how we can best translate those practices into action through our educational strategies. And I think that's one area where, a video might be helpful, and ongoing education to the ISPD community at large about when to do them and how to do them. Because I can say, as a nephrologist who specializes in PD in Canada, I get a tremendous amount of questions around when can we consider a catheter salvage technique. And I know, David, if you want to comment on that.
No, I think that's entirely right. And I must say, Jeff, my practice tends to accord with yours. I tend to do catheter removal if in the case of refractory exit site infections. And there are almost certainly some occasions where it may have been more appropriate to consider a catheter salvage technique. So I think it is important to consider.
So let me ask you a question, as I've been doing. For a purulent exit site infection that is initially culture negative and is not responding to treatment, would you automatically in your program ask for special cultures for atypical mycobacterial? Would you do that from the start? I think you're right, KM. I do think I'm getting a sense that atypical mycobacterial infections are increasing in incidence. And I want to get your perspectives, both of you, as to why. But would you suggest that we ought to think about those culturing techniques for purulent but culture-negative, non-responsive exit site infections?
Yes, I mean, for peritonitis, if we have a refractory peritonitis that's culture negative, we think about atypical organisms. The same should apply to exit site infection.
And I guess my next question is about, do you think that at all the use of these exit site ointments, mupirocin and gentamicin, might be at all responsible for this increase in atypical mycobacterial infections we're seeing?
It's possible. We know that when you apply any topical antimicrobial agents, you alter the local microbiome, you know, and I mean, it's been documented in a number of studies, the MP3, etc., that you do, you know, if you take out one, you know, you tend to get overgrowth of other species, and certainly it may be a factor in, you know, in the apparent rise of things like atypical mycobacterial exit site infections.
And the other question I was going to ask you is, you know, mupirocin resistance has been well described. In the US, at least in the PDOP study, it stands really as an outlier as using the most exit site aminoglycoside of any country, at least that participates in PDOPs. I think that stems from the local evidence, the Peritoneal and Bernardini study comparing exit site aminoglycoside to mupirocin. But I remain a little bit concerned about evolving aminoglycoside resistance. I think programs should be monitoring for that. And I wanted to know how you guys felt about the microbiology of exit site infections and surveillancing for resistance in programs.
Well, yes. Look, I think yes. Obviously, you know, North America, US in particular, uses gentamicin prophylaxis because of that particular, you know, Perino-Bernardini paper. And yes, a lot of other units outside of the US do not use those agents because of concerns of aminoglycoside resistance. I mean, you're promoting resistance to the, you know, the very agents that sometimes you use in the treatment of peritonitis. So we go for something like, you know, mupirocin instead, where you don't have that cross reaction with the agents that you use for treatment. But so, for example, we use mupirocin in my corner of the world, and we do monitor for mupirocin resistance. I think similarly, if you're using gentamicin as your topical prophylactic antimicrobial strategy, then you should be monitoring for gentamicin resistance. And there have been a number of papers showing reports of emerging aminoglycoside resistance where that's used. So it should be monitored, absolutely.
KM, thanks, David. KM, I'm gonna ask you a question. What would you like to see as, if we could get together as an international PD community and do a study to identify an area of need for research in this area, what would you say, KM, would be your dream study to be able to do, your dream randomized controlled trial to fill in an evidence gap in the guidelines?
Very true. We really need a high-level evidence, such as a randomized control trial. For the catheter exit site infection prevention, many of the time we do not involve some drugs, expensive drugs. So we do not expect a pharmaceutical company industry-sponsored trial. And we are talking about the basic interventions, such as covering the exit site, putting some antibiotics or antimicrobial prophylaxis, which is not very expensive, but we need this kind of study to prove which strategy is better or not. In fact, in the 2023 guideline, we also mentioned whether we should ask our patient to cover the exit site 2 weeks after the insertion. We really do not have good evidence. So this kind of strategy should be tested in a randomized control trial. And also, there are also the pooling factors. And if the patient do not really secure and fix the catheter and keep on having traction pulling forces on the catheter, I think this is one way that we can do more to prevent infection. But we should have some high-level randomized control trial to see whether once we ask the patient, randomize him to fixing the catheter, prevent stretching or pulling it, can it really reduce the exit site infection? Then that will be our dream trial.
David, you know, as the grand poobah of trialists in peritoneal dialysis, I hope you don't mind I've coined that term for you. What would you say what would you say would be a really important randomized control trial internationally to fill an evidence gap in the guidelines?
I agree with KM. It really should be in the exit site infection prevention area. You know, there's so much we don't know. What type of cleansing agent we use, whether we should cover be covered with a dressing or not, whether we should anchor or immobilize or not. You know, they're pretty basic things. It would be pretty easy to knock it off with a randomized controlled trial with a bit of international cooperation. And yet we just don't have the evidence. Even the topical antimicrobial agents, as we discussed before, we haven't really got good evidence regarding that. So it's I think something in the prevention space, anything, cleansing agent, dressing, anchoring, one of those things. If we all agreed on a particular, on a particular intervention and just knocked it off, so we could actually have some high certainty evidence for these guidelines.
Yeah, no, and I think that's true, and it's probably the simple things that we have to start with, and oftentimes we don't question them, but we ought to question some of the more basic things. And I just want to make the point here that exit site care and management is really, our nurses are, so diligent at managing and looking after these things that I think that it does, there's a huge responsibility for nurses to be able to examine an exit site properly, flag abnormal exit sites. And one of the things I still am struck with is we do have the evidence base to support many things, but a lot of the evidence isn't being applied. What do you think we can do to improve knowledge translation of the guidelines? How can we make sure that this evidence actually gets translated into practice?
Yeah, well, look, implementation science often lags well behind the actual doing the trials. It's on average, it takes 17 years for a new piece of high certainty randomized control trial evidence to actually make its way into clinical practice. So it takes a long time. I think obviously doing things like this with podcasts and using social media more to try to to disseminate the message. I think I think it's also important to have implementation projects going as well, having change champions in various provincial areas or states, different jurisdictions who drive change, and then and then ensure that I think make sure that if there's a high certainty piece of evidence, a targeted intervention that aims to introduce that and monitors that in a continuous quality improvement cycle is the main way to be able to do that. And you do need local regional champions to be able to foster that. Otherwise, it just doesn't happen. If you just publish an article and hope that people will then implement it, just generally doesn't happen, or it happens very slowly.
Yeah, and I think Australia and New Zealand in particular have done a really great job at rallying together to identify areas in need, and you guys have done that very successfully with improvements in your infection rates over time. KM, I was going to ask you, and one final question here. A lot of PD is developing and growing in low and middle income countries, and perhaps low income countries where resources may be limited. How do you think, someone reading the guidelines from a lower middle income country could adapt these in that setting with less resources, for example, than other countries? Are there higher yield things to focus on in those evolving PD programs in low and middle income countries that you would think about highlighting as part of the guidelines that were just published that we're talking about?
For the low resources countries or less wealthy countries, they may not be able to cover and follow everything from the guideline, but at least the follow-up of the patients and treatment of the peritonitis, the exercise infection should really be following the guideline. Say if they cannot really ask the patient to come back in 1 week for follow-up for treatment, say because the patient are living remotely, then at least we should really think about those telemedicine to hopefully tackle these kind of barriers. Say if the patient cannot come, can you take a picture and then send it over Zoom so that the nurses can look at it and then they can do it. For the training and retraining of the patients, if they have not enough resources, then of course they may not be able to do it. But for the treatment, I think they should follow the guideline.
I'm just going to jump in here and ask, because it is related to that. In the low income countries or income countries where it is not very easy to get peritoneal dialysis going, you know, this recommendation of if the catheter is, if the exit site is not working, then catheter needs to come out and new catheter needs to go in. That is a huge financial burden on these patients, right? And maybe one of the reasons why people are very hesitant to, oh, if I get an infection, I have to pay such a lot of money. So this implementation and how it kind of works out is probably important.
That's an excellent point, Nikhil. So I have found this an absolutely fascinating podcast. I learned a lot from both of you, and I want to thank you guys for taking the time to give us a little bit of the guidelines. I could actually go on with these experts for hours asking all of these questions. And I also want to point out that in the ISPD 2024 meeting in Dubai, I'm sure there will be sessions on these guidelines, so you can pick the brains of these experts and gain more information. And I want to thank you guys so much. This has been a great session. Nikhil, any final thoughts or comments?
No, this has been fascinating. And you know what is more interesting is it's not just discussing the guidelines, but the rationale and the thinking behind why these recommendations are being made. Like, we have a limited evidence base, and so you have to pick and choose. And I think that is very fascinating. So yeah, both Professor Johnson and Professor Chow, thank you so much for this fascinating discussion and these insights. I'm sure this will be a popular podcast. So I will put all the links to the guidelines in the notes for this particular podcast, and I hope to see you again sometime soon on the podcast with new papers. Thank you so much.
Thank you.
Thanks for having us. It's been a pleasure.
And that's a wrap, folks. Links to the paper are in the episode details, and please reach out for comments, suggestions, and questions. Our Twitter handles and email addresses are in the episode details as well. Hope you enjoyed this exchange. This is Jeff and Nikhil signing off until the next PD Exchange. Take care.